Very good afternoon to all of you. I'm presenting the study of association between glomerular filtration rate and the severity of diabetic retinopathy in type 2 diabetes mellitus patient. Diabetes, as we all know, is the leading cause of visual impairment in working age adults. The two types of diabetes mellitus being the 1 and 2, the one being insulin dependent, other being non-insulin dependent. Patients present with gradual paleness, diminution of vision. The microvascular damage leads to various signs, being the retinal capillary non-perfusion, the nerve fiber layer infarcts leading to cotton wool spots, the intraretinal hemorrhages, venous abnormalities, and the intraretinal microvascular abnormalities. The increased vasopermeability results in retinal edema and the hard exudates. The proliferative stage is marked by the closure of arterioles and venules, leading to secondary proliferation of new vessels, which later on bleed and cause tractional retinal detachments and neovascular glaucomas. Studies suggest high prevalence of diabetes in Asia. Duration of diabetes and severity of hyperglycemia are major risk factors associated with development of diabetic retinopathy. But once the retinopathy is present, duration of diabetes is less important factor than the glycemic control in forecasting the progression of disease. All in all, we take HbA1c to be less than 7% as the target glycemic control. The aim of the study was to study the association between glomerular filtration rate and the severity of diabetic retinopathy in type 2 diabetes mellitus patients. The study was a hospital-based prospective study being done in Regional Institute of Ophthalmology, Banaras Hindu University. Ethical clearance was taken. Study was in accordance with the tenets of Declaration of Helsinki. Was conducted between January 2018 to April 2019, with a total of 43 patients being included. Inclusion criteria was patients more than 35 years of age, diagnosed with type 2 diabetes mellitus, and who were willing to participate. Exclusion criteria was patient not giving consent, and the corneal opacities or the lenticular opacities, other media opacities which obscure the fundus details. Method: type 2 diabetes mellitus patients were diagnosed for diabetes retinopathy using clinical fundus examination, fundus photography, and OCT. It was then classified into mild to moderate NPDR and severe NPDR and PDR. Macular edema was also separately evaluated. GFR was estimated based on the MDRD equation and was categorized into 4 groups. Statistical analysis were performed using SPSS version 16.0, and the numerical variables were expressed as mean plus minus standard deviation. P-value less than 0.05 was taken to be significant. Observation was majority of the patients belonged to age group of 50 to 55 years, comprising about 30%, and few were sorry for the typing error. It was 60 to 65 year, 23% of the patient. There was a male preponderance in our study. The mean GFR was 66.2 with standard deviation 25.8. There was a marked high prevalence of mild to moderate NPDR, with about 40% of patients having the same. However, about 11% were having proliferative changes, with severe NPDR and severe NPDR with macular edema being an equivocal presentation. Discussion: patients with marked kidney damage, kidney functional damage, marked by GFR less than 30 ml per minute per 1.73 meter squares, had severe diabetic retinopathy as compared with the patients with GFR of more than 90, which was under the normal kidney functions. Similar findings were also reported in a study done by Kupit et al. In Thailand. Conclusion: decreased GFR was proportionally associated with severe diabetic retinopathy, and GFR should be monitored in diabetic patient for monitoring of diabetic retinopathy severity and for assessing its progression. Thank you. Sir, angiography as such was not performed. We were mainly concerned about the severity of the diabetes retinopathy to classify into severe or proliferative changes, and also to have an assessment of the macular edema by OCT. Sir, it was done on clinical examination, but was for quantified by OCT. FFA was not done. Fundus photograph and 90-day examination.